Hello, I'm Hannah Sachs, Editor-in-Chief of NEJM Evidence, and this is Stat.
Sunday brunch is the best, and this week you're hosting. You decide to make waffles, but which is the perfect maple syrup to go with them? As you scroll through a website that has hundreds of maple syrup reviews, a Canadian and a Vermont syrup seem to be the clear favorites. There's never been a randomized trial comparing Vermont maple syrup to Canadian maple syrup, and you don't have the time or resources to do one before Sunday. Still, is there a way to know which is superior? You know you can't just compare the average scores for each maple syrup on the website because there might be multiple factors beyond just how good the syrup is that determines who writes reviews and the ratings given. There are, in other words, confounders. Things that affect the treatment assignment, here, which maple syrup was sampled, and the outcome, the score given in the review. Enter propensity scores, one approach to adjusting for observed confounders in a non-randomized study. Why are these confounders likely to be so impactful? Well, in a one-to-one randomized trial of, say, medication A versus medication B for patients with diabetes, the probability of a patient receiving one medication or the other is 0.5 for every patient, determined by random chance. Think a coin flip. As long as the sample is sufficiently large, potential confounders, both observed, like age and starting hemoglobin A1C level, and unobserved, maybe exercise amount or diet, will be balanced on average between the two groups. But when you don't have a randomized trial and instead seek to analyze an observational data set of, say, health records, such balance is very unlikely. That's because in the real world, we don't flip a coin to determine which medication a patient receives. That decision depends on a long list of factors, such as a patient's age and other medical conditions, or which medication a doctor perceives to be the safest or uses the most. Some of these factors are likely relevant confounders, and failing to account for them can result in a biased estimate of the association between a drug and a given outcome. So let's dive into how propensity score methods approach this challenge. A propensity score is simply a probability, so it ranges from 0 to 1, that an individual received a specific treatment of interest. The first step is to identify the relevant confounders in the dataset that here include the health records of patients who received drug A or drug B. It's important to include confounders measured prior to receipt of the treatment of interest. For a study evaluating the association between these drugs and major adverse cardiovascular events, you want to know a lot of things: age, sex, presence of kidney disease, among others. You can then estimate the probability of receiving medication A. This can be done using a statistical model, say logistic regression, or using machine learning, say random forests. Regardless of approach, each person in the dataset receives a predicted probability of receiving drug A. For example, maybe older age confers a lower probability of receiving drug A, and presence of kidney disease confers a higher probability. So now everyone has a propensity score. What's next? There are different ways the propensity score can be applied, but two common approaches are matching and weighting. Let's explore one-to-one matching. As the name suggests, you match patients who received medication A to patients who received medication B and have the same propensity score. There are different ways to define what a close enough score means to be a match. As you review your dataset, you see that many, but not all patients have a match, and those without a match are excluded. Your sample size shrinks as a result. But when you compare the distribution of the confounders between the medication arms and the match sample, you see the two groups have balanced baseline characteristics. And with your new propensity score match population, you can now compare the outcomes for patients who receive drug A to the outcomes of those who receive drug B. One important point about propensity scores to keep in mind. It may seem tempting to think that propensity scores mimic a randomized trial, but that really isn't the case. Propensity scores generally balance observed confounders, but don't guarantee that unmeasured confounders are balanced. Ensuring balance of unmeasured confounders is a critical benefit of randomized trials. Back to the pressing task at hand, buying the best maple syrup. You review the website you found and see hundreds of reviews for both Vermont and Canadian maple syrup, as well as characteristics of the people who wrote the reviews. After calculating the propensity score for writing a review for Vermont maple syrup, you apply the score to all available reviews. In the updated dataset restricted to the propensity score match population, you observe that the Canadian maple syrup rating is 1 point higher than the rating for Vermont maple syrup. A meaningful difference. That settles it. You fill up your shopping cart accordingly, and head home to fire up the waffle iron.